We will discuss the issues related to the radial and brachial artery region. When we think of the issues related to this region, we must think of radial artery tortuosity, the atherosclerotic lesion, the calcification, radial artery occlusion, radial artery spasm, perforation, and very importantly loops, how to identify them and how to deal with them. So, we will take up all these issues one by one along with the problems and the solution. Before discussing the issues related to radial and brachial region, it is important to understand the normal anatomy of this region. The axillary artery continues as brachial artery. The brachial artery divides into radial and ulnar artery. There are good amount of collaterals at the palmar circulation, and there are also collaterals in the forearm which are connecting both radial and ulnar artery. Now, we will discuss radial artery spasm. This is an example of focal radial artery spasm right there, just beyond the tip of the introducer sheath. You can see after giving the spasmolytic cocktail, that is 200 mics of nitroglycerin and 5 milligram of diltiazem, how the spasm disappeared. This is an example of diffuse spasm of radial artery. Here is another example of diffuse radial artery spasm. This is a very interesting example. The patient himself is an anesthetist who had the habit of taking morphine. He became actually the addict, and when he spoiled all his arm veins and forearm veins, he started injecting morphine inside his arteries, and ultimately the arteries got fibrosed, and this is how they are occluded. What you see is the extensive collateral circulation which has been established after a long segment total occlusion over here. In this situation, at times you are able to palpate the radial artery pulse so well, your wire also goes up to an extent, but it does not go beyond a particular point, and when you inject through cannula, you will find this sort of situation. This is actually very rare, but it is a very important situation which is to be kept in the mind. Like all other arteries in the body, radial artery is not immune to atherosclerosis. You may find atherosclerotic obstructive lesion inside the radial artery also, and this is an example of atherosclerotic lesions of the radial artery. This is actually an anomalous radial artery which is arising from high axillary artery. Despite repeated doses of the cocktail, we were not able to eliminate these, and this is how we ruled out the spasm, and they were actually the atherosclerotic lesions. This is a nice example of radial and ulnar artery calcification. You can see a clear cut tram track sort of calcification in the root of radial and ulnar artery. The wire is being very carefully negotiated through this calcification. You have to make sure that when you pass the wire through this situation, you negotiate it very carefully. You will encounter some resistance, but fine, the wire will move on. Now, the catheter is negotiated over the wire. You can notice something very important. When you are negotiating a catheter through the calcified segment, make sure that you do not push. You have to do a gentle corkscrew movement to eliminate the friction generated by the calcified segment, and this is how you can negotiate the catheter very nicely over the wire. Once the calcified segment is crossed, there will not be any resistance and the catheter will move very smoothly, and the procedure can be completed in usual fashion. This is an example of long tortuosity of the radial artery. When we tried to negotiate a 0.35 guide wire, we encountered some resistance. Whenever you encounter this sort of resistance, it is very important to inject diluted contrast to the side port of the sheath, and that is what exactly we did, and we were able to find out this problem. Now, once we identified the problem and when we knew that 0.35 wire had difficulty in being negotiated further, we changed our strategy and we used 0.014 soft tip PTCA wire, and we could negotiate the PTCA wire very easily. Very important issue to remember: whenever you are working through this sort of tortuosity, make sure that you are working under fluoroscopic guidance to avoid any injury to this region. Once the tortuous segment is crossed, the wire also will move very smoothly in the further segment. You can see the catheter was moved over the PTCA wire through this tortuous segment, and the procedure was finished in usual fashion. This is an example of a small caliber radial artery which is anomalous actually, which is arising from high axillary region. You can see the small caliber and tortuosity throughout its course. Here is another example of anomalous radial artery arising from the axillary artery. This is one more example of anomalous radial artery arising from axillary artery. Understanding of this particular anatomy is important for a radialist, as radial artery is almost invariably of small caliber and it gives feeling of spasm while negotiating the catheter over the wire. Sometimes you need to downsize the catheter, that is, instead of 6F a 5F guide catheter and instead of 5F a 4F diagnostic catheter should be chosen for smooth and successful completion of an intervention or an angiogram. This is an example of perforation in the radial brachial region. This happened because of repeated push of a standard guide wire despite its not moving further. This led to injury and perforation in the radial region, and that led to extravasation of the contrast just outside in the surrounding tissues. Initially, we used to treat this type of perforation conservatively by giving significant compression locally to prevent the expansion of hematoma. Many times the procedure was deferred for few hours or even next day, and it was done either through the left radial or femoral approach. In last few years, we practice the technique which we have developed to tackle this perforation, and technique has already been published in Journal of Invasive Cardiology in year 2010. Now, I will show you systematically the steps of this technique. Once the perforation is documented, rather than stopping the procedure, you can continue with it. Here we have introduced a PTCA wire through the radial artery across the perforated segment. There was an expanding hematoma, so we had to compress it externally by manual compression. Once the PTCA wire is placed distally, the catheter is being negotiated across the affected segment. May it be a guide catheter or a diagnostic catheter, make sure that you are using a corkscrew movement just to avoid further friction and the affected segment is crossed with the catheter. Once the catheter crosses the affected segment, the procedure is done in usual fashion. While coming back, we have injected the contrast just to make sure that the perforation is sealed and there is no extravasation. It is important to note that the catheter acts as an internal hemostatic device and gives adequate pressure to the perforated region, so that by the time the procedure is over, the perforation is sealed. This is another example of perforation which was dealt with using the same technique. This is one more example of perforation. You can see extravasation, and it was tackled in the same manner. This is another example. I showed you several examples of the technique dealing with the radial brachial perforation. Technique to deal with perforation developed by us is not only effective but also reproducible. Understanding of different loops occurring in radiobrachial region is very important. It gives you confidence to deal with them effectively. The loops can be broadly classified as simple loop, more challenging loop, and most challenging loop. We will discuss this issue one by one, stating relevant examples. This is an example of a simple loop in the radial region. Although it is a 360-degree loop, it has a reasonably good diameter for the maneuverability of a guide wire and a catheter. In this example, we have downsized the guide wire from 0.035 standard guide wire to a 0.014 inch soft tip PTCA guide wire, which has effectively crossed the loop. The OptiTorque TIG catheter has been negotiated over the wire across the loop without any resistance, which is so obvious on this angiogram. If there is no resistance to the movement of catheter and wire distal to the loop, the procedure should be continued in usual fashion. Once the procedure was done, while coming back, we have documented the loop. Note that there is no injury in this region. This is an example of a more challenging loop, which is actually in the brachial region. It is more challenging because the diameter of the loop is smaller. Now you can see the catheter is being negotiated over the wire, and the tip of the catheter is now seen distally to the loop. However, catheter refuses to progress further. Both the guide wire and catheter are now carefully pulled, which unfolded the loop. You can see the beautiful demonstration of this technique. It is worth remembering. Once the procedure was done, we documented the loop while coming back. This is an example of most challenging loop. We can see that the radial artery has taken double hairpin turn. Hence, we will call this loop as double hairpin loop. It is once again being emphasized that whenever you feel resistance to the movement of guide wire or catheter in this region, it is mandatory to inject the contrast to document the reason for it. If you make this as habit, you will be able to pick up this type of rare loops. Once you identify the loop and know how to work through it, it will increase your success rate remarkably. We crossed the loop with a 0.014 inch soft tip PTCA guide wire and tried to negotiate the catheter across the loop. However, we could not go beyond the first hairpin loop. So, we used buddy wire technique. Another PTCA wire was also negotiated across the loop, and now the catheter was able to take the turn at the second hairpin loop. Once the loop was crossed, the procedure was completed in usual fashion. This is another example of most challenging loop. This is a radiocubital trunk. You can see that there is a communicating artery with a good diameter which joins the radial with the brachial artery. You should notice that the diameter of the radial artery becomes very small beyond the point of origin of communicating artery. It is actually an anomalous radial artery which is arising from high brachial region. Avoid temptation of going through a small calibered radial artery because it will almost invariably lead to significant pain and discomfort to the patient, and failure rate will be high. Instead, you aim at negotiating the wire through a bigger branch, that is communicating artery, and enter the large cerebrobrachial artery. Once the wire placement is done, the catheter can be negotiated over it through this region. Once the catheter tip reaches in the brachial region, the procedure can be completed in usual fashion. This is another example of most challenging loop. Note that the diameter of the radial artery is very narrow. We have used buddy wire technique by deploying two 0.014-inch soft tip PTCA guide wires across the loop. A 5F OptiTorque TIG diagnostic catheter refuses to take the last turn of the loop. We have removed that catheter and replaced it with a 5F pigtail catheter. Once the pigtail catheter was placed inside the loop, the PTCA wires were removed. A 0.032-inch standard wire was carefully negotiated through the pigtail catheter across the loop. The unfolding of loop was then done by the technique described before. We redocumented the loop while coming back. This is an example of loop which was complicated by perforation in its proximal segment. It happened because of repeated push of the wire and catheter in this region. A 0.014-inch soft tip PTCA guide wire was carefully negotiated beyond the perforated segment and the loop. A 0.014-inch soft tip PTCA guide wire was carefully negotiated beyond the perforated segment and the loop. The catheter is carefully negotiated using gentle corkscrew movement across this segment. Once the distal tip of the catheter has reached beyond the loop, the PTCA wire was removed and replaced by a 0.032-inch standard wire. The diagnostic catheter was now removed and replaced by a 5F guide catheter, which could be easily negotiated through this region. Coronary intervention was then completed. While coming back, we documented the loop and the sealed perforation. This is an interesting example of a hidden loop. You can see a focal spasm in the distal radial segment, and if you observe more carefully, you can see the vessel above it on the left is becoming end horn. For better understanding of this situation, we decided to take several views. This is an LAO view which opens up the loop, and you can see a small communicating artery going parallel to the brachial artery. The RAO view opens up a double hairpin loop and the communicating artery and its relation. It is important to understand that the spasm occurred because of the repeated push of the catheter and the wire against the hairpin loop. If you miss this loop in this situation, you will end up with the failure to perform the procedure. So, whenever you are in doubt, it is a good idea to consider taking several views of this region, and you have the answer for your problem. A 0.014-inch soft tip PTCA guide wire was then negotiated across the loop. You can see the smooth progress of the wire beyond the loop. The catheter is now carefully negotiated over the wire. The loop is crossed and the procedure is completed in usual fashion. Here is an interesting example of a very low radial loop. After puncturing the radial artery, the needle was removed and there was an excellent backflow of blood from the plastic cannula. However, a 0.025 inch hydrophilic wire available along with the Terumo introducer sheath could not be negotiated. So, we used a soft tip PTCA guide wire which was negotiated through the plastic cannula. While negotiating the introducer sheath, the patient complained of significant pain and discomfort, and we removed the dilator to inject the contrast to understand the problem. To our surprise, we could see a very low 360-degree loop in the course of radial artery, which did not allow the introducer to enter. However, the radial artery segment beyond the loop was quite normal. We did not remove the introducer sheath and PTCA guide wire. Keeping PTCA guide wire as a road map, we did a high puncture in the radial artery and deployed another sheath over there. The procedure was then completed in usual fashion. This is another example of a low radial loop. Through the plastic cannula of the puncture needle, we are trying to negotiate PTCA guide wire which actually refuses to advance further. We then did a contrast injection through the plastic cannula which revealed a low radial loop complicated by perforation. We then punctured radial artery in the higher segment. The procedure was then completed in usual fashion. While coming back, we documented an anomalous origin of radial artery arising from high brachial region. In this case, we could not puncture the radial artery because it was very feeble. The ulnar artery was punctured and we were not able to negotiate the guide wire through the plastic cannula. Hence, we injected contrast through the cannula which revealed a low ulnar loop. We then palpated and punctured the radial artery in higher segment, and injection through the side port of the introducer sheath revealed that it was a separate intermediate artery and there was a small radial artery passing beyond it which also showed a loop in a very low region. And there was a small radial artery passing beyond it which also showed a loop in a very low region. A long cine angiogram demonstrated both low radial as well as ulnar loops. This is an extremely rare anomaly. At times you encounter a radial artery which has extremely small caliber or extreme tortuosity or atherosclerotic obstruction. Sometimes it is difficult to track a diagnostic or a guide catheter further. Repeated attempts to negotiate a catheter will increase the chances of spasm, pain and discomfort and also perforation leading to hematoma. We have developed a technique which is a very effective technique for working through these difficult segments. We describe it as balloon assisted tracking of a catheter. You need to define the anatomy, cross the segment with a 0.014 inch floppy tip PTCA guide wire. If you are using a 5F diagnostic catheter, use a 1.5 millimeter PTCA catheter, and if you are using a 6F guide catheter, use a 2 millimeter PTCA catheter. With 7F guide, you can use a 2.5 millimeter PTCA catheter. Distal 4 to 5 millimeter segment of balloon should protrude outside the mouth of a catheter. These photographs show in vitro demonstration of this technique. The catheter is kept just proximal to the affected segment. The balloon is inflated at 4 to 5 atmospheric pressure and the whole assembly is easily tracked through the segment. Once the segment is crossed, the procedure is finished in usual fashion. This technique has subtle advantage of avoiding friction and razor effect while working through small and tortuous radial segments. Here is a case where we need to do a left main bifurcation stenting using a 7F extra backup guide catheter, and you can see a very small caliber of radial artery through which we need to negotiate a 7F EBU guide catheter. Repeat spasmolytic cocktail showed some improvement, but not good enough to track a 7F guide. As discussed, we performed balloon assisted tracking. A complex LMCA bifurcation lesion is seen now. Optimal end result is seen now. Now, I will show you another example of anomalous radial artery arising from axillary artery, having small caliber, atherosclerotic lesion and a sharp hairpin loop in the brachial region. Catheter over a PTCA wire refused to cross the hairpin loop. Balloon is brought in the proximal segment. Now, balloon assisted tracking was used to cross the loop successfully. While coming back, angiogram documented no damage or razor effect to the radial artery.